Your physician glances at the monitor and reads the result out loud. 151/79. Two numbers. And almost instinctively, your eyes go to the second one. 79. That seems fine. That seems safe. And somewhere in the back of your mind, a quiet reassurance settles in. The lower number is holding steady. How bad can it really be? I need you to understand something important about that reassurance. It is not protecting you. It may actually be working against you. After spending close to 2 decades in the field of cardiovascular medicine, seeing patients at every stage of their journey with heart disease, before things go wrong, and in the difficult aftermath when they already have, I have had a version of that same conversation more times than I can count. Someone sitting across from me, chart in hand, pointing at the bottom number on their blood pressure reading as though it were a clean bill of health. And what I have to tell them, what I wish someone had told them years earlier, is that after the age of 60, the number that determines your real cardiovascular risk is the one on top. The systolic reading. The one that was elevated. The one they were not watching. The way blood pressure works in your body changes as you get older. Not slightly. Not in ways that only specialists would notice. It changes in ways that completely reframe which number matters most, which pattern signals danger, and what you can do about it. Most people were taught the basics of blood pressure management sometime in middle age. Keep an eye on it. Reduce salt. Maybe lose a little weight. And those lessons came with an implicit focus on the diastolic reading, the bottom number, as the primary measure of cardiovascular health. For decades, that was the prevailing clinical emphasis. High diastolic pressure was considered the principal threat. But the body you have at 65 is not the body you had at 45. And the cardiovascular system operating inside, it follows different rules. Here is the foundation of everything else I want to share with you today. After 60, the walls of your major arteries are no longer the same flexible, resilient structures they were in younger decades. They have stiffened, and that single biological reality changes the entire picture of blood pressure risk for this stage of life. Think about a brand new rubber hose. Soft, pliable, capable of flexing and bouncing back. When water rushes through it, the walls give slightly. They absorb some of the force. The pressure is managed, cushioned, distributed. Now imagine that same hose left outside through years of heat and cold and sun exposure. The material has hardened. It no longer gives. When water rushes through it now, there is nowhere for the force to go except straight into the walls and straight through the system. All the pressure that used to be absorbed is now transmitted directly. That is a reasonable approximation of what happens to human arteries across a lifetime. The elastic proteins in arterial walls are gradually replaced by stiffer collagen fibers. Calcium deposits accumulate. The smooth muscle that helps regulate vessel tone becomes less responsive. The net result is arteries that are less able to expand with each heartbeat and spring back between them. And when the heart contracts and sends blood out into that stiffer system, the peak pressure, the systolic reading, spikes higher than it would in a younger, more compliant vascular system. Meanwhile, the diastolic pressure, the reading between beats, may stay flat or even drift downward. The result is a pattern that is extremely common in adults over 60 and profoundly misread by most of the people who have it. High systolic, normal diastolic, top number elevated, bottom number reassuring. And because people have been conditioned to look at the bottom number, they look at the reassuring one and move on. This pattern has a name. Isolated systolic hypertension, a systolic reading at or above 140, combined with a diastolic reading that stays below 90. And it is one of the most significant cardiovascular risk factors in the older adult population. Not a quirk, not an artifact of aging to be accepted and set aside. A real and well-documented driver of heart attack, stroke, and heart failure in people over 60. The data on this is not subtle. Research tracking older adults with this exact pattern has found that each 10-point rise in systolic pressure above 140 corresponds to approximately a 20% increase in cardiovascular risk. Someone sitting at a systolic of 160, which is only 20 points above that threshold, is carrying roughly 40% greater risk than someone at 140. And if their diastolic is a comfortable 76, they may feel completely fine. No symptoms, no warnings, no reason to think anything is wrong. That is the trap. Isolated systolic hypertension almost never announces itself through how you feel. There are no reliable physical symptoms in the early and middle stages. People live with it for years, feeling perfectly normal, while the elevated pressure works silently on the most vulnerable structures in the body. The brain is among the most immediately affected. It depends on a continuous, finely regulated blood supply delivered through vessels ranging from moderately sized arteries down to capillaries barely wide enough for a single red blood cell to pass through. Those smallest vessels are the ones that bear the heaviest burden of chronic pressure elevation. Each heartbeat sends a mechanical pulse through the entire vascular network, and in a stiffened, high-pressure system, that pulse arrives with more force than the delicate cerebral vessels are designed to tolerate thousands of times a day, every day, across years. In response, those vessel walls thicken. The internal channel through which blood flows narrows. Small areas of brain tissue begin receiving less circulation than they need. Microinfarcts form, tiny areas where blood supply has been interrupted entirely. None of this is felt. None of it produces a dramatic event. It accumulates invisibly, and what shows up over time is a pattern of gradually declining cognitive function that is frequently and incorrectly attributed simply to getting older. Memory becomes less reliable. Word retrieval slows. Complex tasks require more effort. The sharpness that used to feel effortless now requires concentration. What makes this particularly important to understand is that this kind of cognitive decline, driven by vascular damage in the brain, can look in its early stages nearly identical to Alzheimer's disease. The memory gaps, the confusion, the processing slowdowns. Experienced clinicians sometimes find it genuinely difficult to distinguish between the two. But unlike Alzheimer's, cognitive deterioration caused by blood vessel damage in the brain is substantially preventable. Keeping systolic pressure well controlled through the 60s and 70s is one of the most powerful tools available for preserving mental sharpness and independence into older age. Not just heart protection, brain protection, the ability to stay present, engaged, and cognitively intact for the people and experiences that matter to you. The heart itself also bears the cost of chronically elevated systolic pressure in ways that deserve clear explanation. With every contraction, the heart is pushing blood out against whatever pressure is waiting on the other side. When that downstream pressure is consistently high, the heart works harder with every single beat, all day, every day. The left ventricle, the main pumping chamber, responds by thickening its walls, the way any muscle does under sustained overload. This sounds like strength. It is actually a progressive loss of efficiency. A thickened ventricle is stiffer, less able to relax and fill properly between beats, more prone to the kinds of electrical disturbances that cause arrhythmias, and significantly more likely over time to develop into the condition known as heart failure. Heart failure in older adults is both common and genuinely difficult to manage once it is established. Preventing it is incomparably easier than treating it. The kidneys are filtering your blood continuously, passing it through an intricate network of microscopic vessels that are highly sensitive to pressure. Chronic systolic hypertension damages those vessels gradually and silently. Kidney function declines. The damage accumulates over years before routine blood tests detect anything abnormal. By the time a standard blood panel raises a flag, the kidneys have often already been under pressure-driven assault for a very long time. The eyes are similarly vulnerable. The retina is lined with small blood vessels that can be damaged by sustained elevated pressure over time, leading to gradual vision impairment and, in more serious cases, to acute vision loss that can be permanent. This is why elevated systolic pressure in older adults is a whole-body problem. The pressure is distributed through the entire circulatory system, and the damage follows it everywhere the blood goes. For most adults over 65, the evidence-supported target for systolic pressure is below 130 millimeters of mercury. Not 140. Not close enough. 130 is the number that clinical trial data consistently associates with meaningful reductions in heart attack, stroke, and cardiovascular death. A landmark trial that followed thousands of adults over 50 was stopped ahead of schedule because the benefit of tighter systolic control was so clear and so substantial that continuing to withhold that level of treatment from the comparison group was considered unethical. The science on this is not ambiguous. Lower systolic pressure after 60 saves lives. Now let me tell you what you can do about it, starting this week, without waiting for a medical appointment. Sodium intake is the first and most immediate lever available to most people. The kidneys clear sodium less efficiently as they age, which means that the same amount of dietary salt that your body handled comfortably at 45 now produces a more sustained effect on blood pressure. The recommended daily ceiling for older adults managing their pressure is roughly 1,500 to 2,000 milligrams. A single teaspoon of table salt already contains about 2,300 milligrams. The most significant sources of sodium in most people's diets are not the salt shaker, but the processed and packaged foods that contain sodium as a preservative and flavor agent. Things like commercially prepared bread, canned soups, deli meats, and restaurant meals. Reading nutrition labels and making consistent choices around lower sodium options can move systolic pressure by a meaningful amount over weeks and months. Body weight is the second lever. Every 10 pounds of excess weight corresponds to approximately 4 to 5 points of additional systolic pressure. Losing those 10 pounds reverses that contribution. This is not about appearance. It is straightforward hydraulics. Less body mass means a less demanding vascular network and a lower pressure baseline. Regular aerobic physical activity is the third, and in some ways the most powerful, because its benefits go beyond simple calorie expenditure. Sustained moderate-intensity exercise, about 30 minutes most days of the week, brisk walking, cycling, swimming, anything that elevates heart rate into a moderate range consistently, has direct effects on arterial wall health. It stimulates the maintenance of elastic tissue in vessel walls. It supports the function of the endothelial lining that regulates vascular tone. It is one of the few interventions with evidence for actually slowing the arterial stiffening process itself, not just managing its consequences. When you move your body regularly, you are doing something real at the cellular level of your arteries every single time. Stress management is the fourth area and the one most frequently underestimated. Chronic psychological stress sustains elevated levels of adrenaline and cortisol, both of which drive systolic pressure upward as a direct physiological effect. Structured practices that engage the relaxation response, whether meditation, controlled breathing, yoga, or regular time in natural environments, have been shown in multiple studies to reduce systolic pressure by 4 to 6 points over time. That is comparable to the effect of a low-dose antihypertensive medication. It deserves to be taken seriously as medicine. When medication is part of the picture, I want to address directly the cultural resistance that surrounds it. There's a persistent narrative that needing blood pressure medication represents a failure of lifestyle discipline. That with enough effort, enough exercise, enough dietary care, medication could be avoided. This idea causes people to resist starting medications their doctors recommend, to take them inconsistently, or to stop them quietly without discussion. And the consequences of that resistance are serious. The arterial stiffening that drives systolic hypertension in older adults is a structural change in tissue. Elastic fibers have been replaced by collagen. The architecture of the vessel wall has been altered by decades of biological aging. Lifestyle changes can slow this process and reduce its impact. They cannot reverse the changes that have already occurred. For many people over 60, achieving a systolic below 130 requires medication alongside lifestyle modification because their biology requires it. That is not a failure of effort. It is a physiological reality, and responding to it with the tools that have been proven to work is an act of intelligent self-care, not weakness. The medications used for systolic hypertension are among the most extensively studied in all of medicine. Their benefits are well established across millions of patients. Taking them consistently, as prescribed, is among the most protective things a person can do for their long-term cardiovascular and cognitive health. The single most underused tool in blood pressure management for older adults is something that costs very little, requires no prescription, and provides information that nothing else can replicate. It is a home blood pressure monitor and the simple daily habit of using it correctly. Office blood pressure readings capture a single moment in a clinical environment that many people find inherently stressful. A significant proportion of patients show elevated readings in medical settings that do not reflect their actual everyday pressure. This is called white coat hypertension, and it can lead to unnecessary treatment escalation. But the more dangerous mirror image of this pattern, and the one that receives less attention, is called masked hypertension. Pressure that appears controlled in the office while running significantly higher at home during the actual conditions of daily life. The patient leaves each appointment reassured. The damage continues to accumulate undetected. Home monitoring closes that gap. A validated upper arm cuff, 2 readings taken morning and evening after 5 minutes of quiet rest, recorded consistently, provides a portrait of real-world pressure that transforms the quality of clinical decision-making. That log of readings, brought to every appointment, tells a physician what is actually happening inside the cardiovascular system across the full range of a patient's daily experience. It reveals morning surge patterns. It shows whether medication is maintaining control throughout the day. It captures the effect of stress and activity in real time. It is, in many clinical situations, more useful than any number of office measurements. The practical commitment is minimal. 5 minutes twice daily. A notebook or a phone note to record the results. Consistency over time. That habit, practiced regularly, can be the difference between catching a concerning pattern early and discovering it only after something serious has already happened. If there is one thing worth doing in the coming week, let it be this. Measure your systolic pressure twice a day for 7 days, morning and evening, and write down every reading. At the end of that week, you will have real information about your own cardiovascular situation that you almost certainly do not have right now. You will have the foundation for a genuinely informed conversation with your physician. And you may find that the number you have not been watching has been telling you something important all along. The physiology of an aging cardiovascular system is not entirely within your control. But the choices made in the years when prevention is still fully effective, those belong to you. Every consistent walk, every sodium-conscious food decision, every blood pressure reading recorded in a notebook, every medication taken as prescribed, these are real actions with real biological consequences. They're working in your favor every time you choose them. The question of whether elevated systolic pressure becomes one of the defining forces of your later decades, or one of the things you addressed before it could be, is still open. And for most people hearing this right now, the answer still depends significantly on what comes next.